Hello, everyone. Thank you so much for joining today. We still have a few people joining, but we're going to go ahead and get started with today's event. My name is Jenna Groman. I'm the Director of Global Communities of Practice at the Sabin Vaccine Institute, and it's my pleasure to welcome you to today's session, Applying Human-Centered Design to the COVID-19 Microplanning Process, Lessons from GA South in Ghana. Next slide, please. A few logistics before we begin. Please remain on mute during the presentation, but we do hope you all engage in dialogue using the chat feature today throughout the session. You can ask questions or share your experiences with other participants. We will have time for questions and answers at the end of today's session, and we will be using the questions that are posted through the chat. So please, as you have any questions for the speakers today, please make sure you are sharing them there. You'll also be able to raise your hand if you'd like to ask a question live during the Q&A portion of the chat. I see a number of people already introducing yourselves in the chat, but if you have not, please do test the chat now and share your name and where you're joining us from today. Next slide, please. Today's event is being hosted by the Behavioral Science for Immunization Network. This is a group of immunization professionals and behavioral science experts who are exploring how to apply behavioral science tools, methods, and approaches to the delivery of immunization activities. We welcome anyone who's on the call today or any of your colleagues to join the network through Sabin's Boost community. There's some directions on the screen and the link will be posted in the chat as well. Next slide. And now it's my pleasure to introduce you to our speakers today. We have Emmanuel Nuworzah. He's a senior program specialist in immunization at JSI. Jones Anim from GA South, who's an EPI officer, and Lisa Oot, a senior technical officer in immunization at JSI. And I am going to turn it over to Lisa to get us started today. Thank you.
Hi, everyone. Thank you for joining us, and thank you, Jenna. I really do hope that if others have experience using human-centered design or other participatory approaches in microplanning, that you please share your experiences in the chat as well. We'd love to hear from other people's experiences and really facilitate that cross-learning. So just to say that. All right, thanks. Next slide, please. So we are going to talk through, as Jenna was saying, applying human-centered design to the COVID-19 microplanning process. And these are some lessons that we've been learning through monitoring, evaluation, and learning processes over the past couple of months. So next slide, please. So Jenna did give a brief introduction, but we are presenting today on the Ghana-specific work that we're doing through the Behavioral Science Immunization Network project, which is funded by the Bill and Melinda Gates Foundation and implemented by JSI and Sabin's Vaccine Institute and the Boost community. We are working both at global and at country level. And today specifically, we're going to be talking about our work in Ghana and our partnership with the Ghana Health Service, where we're working to strengthen the capacity of immunization practitioners to use behavioral science to improve vaccine confidence and uptake. And specifically, we're going to talk about collaboration with district and sub-district health leaders to use human-centered design to develop and test behaviorally informed interventions with a focus on increasing COVID-19 vaccine uptake. I'll just note we had a session 2 weeks ago where we presented on our work in Nepal, and that work was focused on routine immunization. So I hope you'll go back and join that session if you didn't have an opportunity to see that. Just a little plug. All right, next slide, please. So a bit about the context and what we were seeing in Ghana. So at the time of our planning, this was in August, last August, according to administrative data, 36% of the eligible population nationally in Ghana was vaccinated against COVID-19. And we saw that vaccination rates were starting to stagnate. And when we were talking with Ghana Health Services and EPI, there really was limited knowledge of why there was low vaccine acceptance, and particularly among different populations within the country. So why pick GOS South? So when we were looking at coverage levels, GOS South actually had one of the lowest levels of coverage for COVID-19 vaccination, and is also in one of the top 10 districts with the highest number of unvaccinated children. This is for routine immunization. And for those of you who don't know, GOS South is a district within Accra, the capital city of Ghana, and it's an urban setting. In addition, 3 years ago, we did an ideation workshop focused on integrating and applying human-centered design to second year of life vaccination in the GOS South district. So wanted to capitalize and utilize that initial learning that had taken place a few years ago. So that's why we selected GOS South. Next slide, please. And so looking at the problem that we were facing, low vaccination uptake, wanting to understand the reasons behind that, we wanted to apply behavioral science to try to address that. And we wanted to integrate tools and approaches into existing platforms and strategies so that it could be a streamlined process that the Ministry of Health could utilize and expand and scale. And so one reason we wanted to take tools from human-centered design was that human-centered design enables us to better focus on the needs, perspectives, and experiences of individuals and also communities. It can help identify both those behavioral and social drivers of vaccination uptake, and the process itself engages community members in both designing and implementing solutions that are really responsive to their own needs and ideally can help reduce behavioral and social drivers that are affecting their ability to get vaccinated. And so we've found through implementation in other projects, so in Ethiopia, in Uganda, and other places, we've integrated really community engagement, participatory engagement into microplanning, and wanted to try that here in Ghana as well, specifically with COVID-19 microplanning. It's a tool that is really critical to being able to address barriers and develop actionable solutions. And so we wanted to integrate human-centered design into the microplanning process so that we could really try to identify and then address barriers to service delivery and access and demand for services. Next slide, please. So WHO and UNICEF have put together a really great guide that's called Human-Centered Design for Tailoring Immunization Programs. It's linked on the Boost platform if you would like to have access to it, and we can share it out as well. And this is really designed for use at the health facility level. And so one thing that we wanted to do with our HCD microplanning workshop was to explore really how to engage communities into the design of microplans with the goal of increasing demand and access to COVID-19 vaccination. So we wanted to identify barriers and enablers of COVID vaccination uptake and design interventions with community members to really be able to increase vaccine confidence and uptake. The workshop was designed over a 4-day period in 2 distinct phases. Phase 1 was focused specifically on health providers. We wanted to do this so that the health providers would have an opportunity to build some skills in human-centered design processes and approaches, and so that we could talk through how we were going to integrate this into the microplanning process. It was also an opportunity to provide some refresher on immunization microplanning, and particularly the COVID-19 tools is newer for some health facilities. The second phase of the project of the next 2 days included community members. And this was where we had community members and health workers working together to identify both enablers and barriers to vaccination uptake and to do some localized problem solving. And it provided an opportunity for the health workers to practice some of the skills that they had learned in phase 1, the previous 2 days of the workshop. Next slide, please. So our kind of quick kind of outputs of the journey. So we found that using end user personas and journey maps were really helpful tools in helping us to explore the journey one takes from non-vaccination all the way through after service delivery, post-vaccination. And so what does that journey look like on a really individualized level, both for community members, as well as for health workers? And so user personas, we developed several different user personas and then followed those along the journey to health map. We also utilized HCD tools to help prioritize challenges and also help us prioritize which interventions we should be using to then integrate into action plans. Then each health facility split up into groups and designed an action plan specifically for their catchment area. So they work with their community members to identify those really specific barriers, and then proposed localized solutions to those barriers and implemented them into their action plans. And we can also share this. We have a report if people are interested in seeing what those are. Next slide, please. And these are just some great photos from the workshop. So we wanted to really understand how applying human-centered design to the microplanning process, what did that look like for both health workers and also community members? I think some of our questions really focused on, is this process more effective, useful, helpful? Is it feasible to do? Hearing that from health workers and health providers themselves, and then also really understanding from the community perspective some of those same questions around their engagement with the microplanning process. So what we did was we did pre and post workshop questionnaires specifically for health workers. They were semi-structured and Likert type questions. So we had 23 health workers that did the pre-test and then 17 that did the post-test. We also had a post-workshop questionnaire specifically with community participants, and that was a semi-structured interview question with 24 interviews. We did a rapid qualitative analysis using intensive team-based process to do that analysis and triangulate data both from the health worker and the community perspective. Next slide, please. So I'm going to spend a few slides talking specifically about the feedback from the community members' perspectives. My colleague Emmanuel will then talk us through some of the health worker perspectives. So just as a reminder, these next slides are focusing on what the community members have told us. Next slide, please. So what we learned from talking with the community members is that for a majority, 23 of the 24, this was their first time ever participating in microplanning. It was a new experience for them. What we learned from them is that the workshop helped community members to better understand the importance of vaccination, the benefits of vaccination, how to educate other community members about the importance of vaccination, and also specifically answered some of their questions around COVID-19 vaccines specifically. The community level vaccination process, the community also had better understanding of the vaccination process. What is the planning process? What goes into creating that delivery plan? And what does monitoring look like? They also gained some perspectives on some of those service delivery constraints that health workers have. So help to give them some insights into some of the challenges that health workers have in providing services as well, which they found really useful. Next slide, please. So we also wanted to understand from health workers if they felt comfortable talking and sharing about their experiences during the workshop. And we found kind of unanimously that people felt that the facilitators and the health workers did a really great job of making them feel included, giving them space to share their opinions. And the community members talked about, working in groups made them bold to share their thoughts and be able to feel free sharing their own experiences. When we talked with community members about the barriers that they face for COVID vaccination, the most common barriers mentioned were lack of access, concerns around vaccine-related myths, and also poor interpersonal communication with health workers. I won't go through those, but those were kind of unanimously talked through among a lot of the participants. Next slide, please. We also found that and asked community members about specifically the human-centered design activities and tools, and community members responded that they felt the tools were both useful and helpful, and also largely easy to understand. Community members appreciated the end user persona specifically because it helped them understand and emphasize with others. So other personas, they know their experience, but this helped them to recognize others within their community who may have a different experience than them. Respondents did have mixed feelings about the Journey to Health map. It was overwhelmingly cited as a favorite tool. However, we did get some feedback that it was difficult. And so what we took this to mean is that the tool really is a valuable tool, but that there also needs to be clear and kind of additional training to help both health workers and community members use the tool itself. Next slide, please. Last, we wanted to ask about if community members felt comfortable then kind of post-workshop talking with their friends and relatives about COVID-19 vaccination, the action plans, and the microplanning process. What we heard from the community members is that they thought it really was a good idea for them to be engaged in microplanning because it offered them a specific opportunity to share very specific contextual barriers and also solutions to problems. It expanded the ownership of the action plans to the community. So both communities and health workers developed the action plans together, and were both collectively accountable for those action plans. They said it would increase their commitment to vaccination, and they also thought that it would make vaccinating the community easier. Here are a couple quotes. I won't read all three, but the first one, involving the community people makes the entire exercise smooth and less stressful, and it's easier for people to accept the vaccine willingly. Next slide, please. So now I'm going to hand the presentation over to my colleague, Emmanuel, who will talk through the data that we collected around health worker perceptions of incorporating human-centered design into the microplanning process. So Emmanuel, over to you.
Thank you very much, Lisa. I'm going to present on the data from the perspective of the health workers. Next slide, please. Yeah, so this data I'm going to talk about, one is prior to the workshop and then the other after the workshop. So approximately half of the health workers said they had heard about HCD, which is the human-centered design, and then most also identified it as a problem solving tool or approach. And then some said they knew that HCD involves understanding and engaging stakeholders, which of course we talked about their engagement with the community stakeholders that Lisa mentioned earlier on. And most could not also name any steps of the HCD, despite the fact that they had heard about HCD or for that matter. Then after the workshop, most said they had heard, or they had heard it during the workshop, and therefore they were able to see the various steps as diagnosing designing, implementing, and then evaluating. And in the workshop, they also mentioned how they themselves could apply these steps that they were learning about. And they had also identified how HCD builds the existing, that the HCD is built upon the existing motivation, the ideas, and then also the limitations. And therefore, there were situations where they had gone beyond the borders and were even asking or adding on things that weren't even within the scope of the COVID-19 vaccination that we're dealing with. And then they also felt that they could use HCD for microplanning, which they have been doing from time to time without using HCD. But for those of you who are in the health sector know that there's usually the traditional microplanning template that is used and is that content is usually by the health workers who sit down and plan for the community, and then they get into the community, and then they implement by themselves. And some of the quotes we have are that my training has equipped me with the knowledge to use HCD for microplanning. The other is I'm able to solve other problems using the HCD approach. So this shows their understanding and the fact that they are beginning to grasp and could and were getting ready to apply this in other health activities in their various directorates. Next slide, please. So the next was health workers see value in incorporating HCD into microplanning, and a number of values that they mentioned include that leads to better understanding of the barriers to vaccination, and which usually were based on what the health workers just taught, but including the HCD into the microplanning brought the real barriers and enablers from those who happen to be the end users, and that's the communities. So that understanding became a better one for the health workers. They also mentioned that it boosts community ownership, which of course they know that the community once committed and sitting around the table to commit to do the micro planning with them would mean that they are prepared to support in every way when during the implementation and even during the evaluation and measurement of progress. And also, they also mentioned that it addresses vaccine misconceptions, since they also have the information, the myths and misconceptions at their fingertips, which are related to what happens in their various communities. They also identified the context-specific challenges and solutions. So they mentioned the barriers clearly, and even from their own perspective as leaders. Then increased vaccine acceptance. It increases vaccine acceptance, motivates community members to share vaccine information, and then increases understanding of vaccines. So these are some of the values that they associated to incorporating HCD into microplanning. And one could say is that with the involvement of the end user in HCD, the community members and staff understand and learn new ideas about the problem. And this does not happen in microplanning. So this means that incorporating the HCD into the microplanning has improved and also improved the scope, and also given a better understanding of what the situation is for solution. Next slide, please. Now, health workers support incorporating HCD into future in microplanning. Yes, and so the first component looked at health workers understand and can use HCD tools on their own in future microplanning. Yes, and here we are stating that most useful tools include diagnose and design, and then the journey to health, which of course during the training, they use the journey to health to understand or underscore the barriers that the community members who sat at the table with them were bringing out. And then it's also help them to work the journey with the community members. So they all ended up agreeing on what the barriers are and relied on each other to understand the enablers for action. Also, health workers may need additional training. Yes, in that scope, being a new concept to them, even though they have heard about it and they are learning of the steps for the first time. At the end, you could see that they really are poised to let the action go and work with it, but with their understanding of the barriers and limitations that are involved, they need more training or further training to deepen the knowledge and also sharpen the skills that they are learning that to use on their own and with the communities. The second being health workers identified few challenges to incorporating HCD into future microplanning. Of course, being the first time, like I said earlier on, we expect that this would happen. So most stated that they do not envision challenges, but a few challenges were, came up from them. And this included community members identifying barriers that can't be addressed. So these are situations where the community members thought that these are opportunities for them to also come out with the other things that were related to health issues, social issues that impacted on health and so on. So they wanted to bring all out because they felt the environment was cool and they could, they had the chance to work with the health workers. So there were some issues that were brought up but were not related. They were, accommodated anyway, and they had the understanding that this could be solved elsewhere. Then adapting to new process, and like I said, the pedestal being new had to be gentle and also needed time to be mastered. One other barrier that they brought was that of financial constraints. That sitting and with the community members and engaging them in planning, they had seen that resources would be needed to, especially in the area of COVID-19 uptake, reach more people, undertake further strategies that could help in demystifying myths and myths, and also making sure that access, especially to those in urban poor communities, could be reached with COVID-19 vaccination. The third being health workers recommend HCD incorporated microplanning for other services. So this is where they think that delivery of other vaccines could have the opportunity. For example, if now that Ghana is coming up with a malaria vaccine implementation, they think that this is a fertile ground that this could help in rolling out the malaria vaccine, for example, and then also in the distribution of the long-lasting improved nets for malaria prevention in the community. They think that HCD incorporated into microplanning could help in making sure that all these services are appropriately planned for, delivered, measured, and appreciated by both the community members and the health workers. Next slide, please. Now, when the quantitative data that we collected, 23 health workers participated. This dropped later to 17. And in the responses, we would find the strongly agree, neither agree nor disagree, and so on. Next slide, please. Now, following the microplanning workshop, all respondents agreed on, or strongly agreed they feel comfortable using ACD in the microplanning process. So after the microplanning, you could see that even though the number dropped to 17, the number of people who strongly agreed is high compared to the previous. Next slide, please. Next slide, please. Yeah, microplanning with ACD will make it easier to generate ideas with the end user in mind. And here you could see that before and after the workshop, almost all respondents agreed to or strongly agreed that microplanning with ACD will make it easier to generate ideas with the end user in mind. And here, those who strongly agree, that's why the drop in the number of respondents. You could see that the number of those who strongly agree is great. Next slide, please. Now, microplanning with ACD will help me better understand the vaccination-related perspectives and needs of people in my community. And here we're saying that that almost all the respondents felt that microplanning with ACD will help them better understand the vaccination-related perspectives and needs of people in the community. And this is underscored here with the number of strongly agree being showing that, yes, most of them agree to that or strongly agree to that. Next slide. The microplanning with ACD will result in different vaccination activities. Before and after the workshop, almost all respondents felt that ACD, incorporating ACD into microplanning would result in vaccination activities that are different from, and like we said that they gave the example of malaria vaccination rollout, and then also the distribution of LLINs. This shows that they are grasping, or they've already grasped the other values that they could achieve, or the other ways by which incorporating ACD into microplanning could lead to solving other health issues in the community. Next slide, please. Now, microplanning with ACD will result in improved COVID-19 vaccination intervention. And here, respondents who strongly agreed that microplanning with ACD will improve vaccination intervention increased. Yes, so you see that those who strongly agree and those who agree are more, with just one standing out as disagreed, even though the number dropped from the 23 to 15. Next, please. Yeah, so at this point, I would hand over to my field partner from the Ghana Health Service, Mr. Jones Anim, to talk about the intervention implementation after the training, to run us through the intervention and then also talk about other related things on the field. Over to you, Jones. Thank you.
Thank you so much, Dima. All right, so I'll talk about the intervention, how we implemented it. In South, we have 4 sub-districts, but this intervention was implemented in 3 out of the 4. And the activities were planned to coincide with the national COVID-19 vaccination campaign that was slated for December 14 to 18. And the problems were context specific, and so were the solutions. And because the sub-district or the stakeholders from the community were part of the ideation, they were also part of the solution. So the strategies or the activities that were lined up to address the challenges were also context specific. So for instance, if you take one of the sub-districts, Amanfo, their activity was to identify and use community information centers and also public address system to share information on COVID-19 to the public. So this came to bear during the ideation that there are possibly a number of community information centers in the communities, and new ones have sprung up that the health system were not even aware. And because the community members came from the community, they brought these issues to light and they were part of activities. Also, the use of public address system to share COVID-19 information, to the population was something that we were using. But this time, the strategy was re-emphasized. There were a lot of impetus into it, and it brought a lot of results. If you look at the next sub-district, Botiano, for instance, their plan or the activity was to train some health promoters to support with SVCC activities. In all, Botiano was able to train 10 of the health promoters in SVCC to support with the information regarding COVID-19. Also, they wanted to provide health information at child welfare clinics, OPD, churches, and also CIC. So these were part of the activities that community members themselves, together with the health workers, brainstormed and came out with, and they implemented this under sub-district. Then if you take the last sub-district, Obom, for instance, they wanted to establish new vaccination centers in locations that were based on the community members' preference. That means that hitherto, there were a lot of satellite communities that are springing up, that COVID-19 vaccination services were not extended to these communities. So as part of the measures to increase coverage, it was planned that new vaccination centers should be established in these new communities. Then after the centers have been established, there was a need for people to know that we have this center here. So there was a lot of publicity in those communities to direct them to the areas that the new centers have been established. What was the result? During the 5-day campaign that was implemented, as I said, from December 14 to 18, the municipality achieved 96.2% of its target. And in fact, it was the highest in recent months. In 2022, the municipality, or as a country, we ran a lot of back-to-back campaigns. We ran about 8 campaigns in 2022 alone. And the one that we implement ACD, that was the December one, yielded the highest result. What we want to say is that those 3 sub-districts that the intervention was implemented, they contributed 80.5% of the total coverage of this 96.2% that I spoke about. So you can see that the 3 sub-districts contributed to a chunk of the coverage. We want to emphasize that while we cannot directly attribute the coverage, the improvement in the coverage to the activities as we have outlined above, we can say that BeSin and the JSI project directly contributed to the establishment of these new vaccination sites. And for this, we want to thank BeSin for that wonderful support, because hitherto these centers wouldn't have existed, but for the ACD campaign or the ACD program where community members were drawn from the community, all these interventions or all these solutions were brought to bear. Next slide, please. So what lessons have we learned? We have learned a lot of valuable lessons. One, we think that when you include community members in microplanning, it's a great idea because it brings a lot of practical issues to bear. It also allows the stakeholders to be part of the decision-making process. And this is what we saw during the implementation of the intervention. And this makes it very easy for the community members to offer their support when it comes to national programs. Also, we reckon that the ACD training and the implementation of the validated microplan have become an indispensable tool for the municipal health directorate So going forward, we know that we can always count on this process. We can always count on these tools when we want to address any public health related issues in the catchment area. On the part of staff, you can say that the knowledge of staff have increased. Hitherto, you must say that some were aware of ACD, but they were not aware of how to apply the tools. But after the training, now almost all the 23 workers who came can now apply the tools, even though some said that they may need some further training. So we have acquired new knowledge and skills that will help us to plan future campaigns. On the side of community members, now community members feel ever closer to the health directorate, because hitherto they didn't see themselves as part, because always the health system will plan the interventions and implement it. But now they were part of the decision-making process, and they were part of the solutions. So now on the WhatsApp page that we created, always you see new ideas that are being poured onto the page from community members. And we feel that this is a good thing. So now we feel the brotherhood, we feel the love, we feel what we can share between the health system and the community members. This has brought a lot of sustainability issues and ownership, because they are part of the whole thing. Now, even if BeSin ends the project, I think that community members' capacity have been built to support the health system to profess solutions to issues relating to immunization. Also, we also want to state that when you incorporate ACD into microplanning, it helps to improve in the coverage of immunization, as the recent data showed. After the 14th to 28th, after the 14th to 18th program, we have run about 3 campaigns, and the communities and the sub-districts were encouraged to keep on using the ACD tools, keep on using the information that they had from the training. And I bet you, if you compare those coverages, the old ones doesn't come near or doesn't come closer at all, not even when the vaccines were rolled out initially. So we think that we have learned a lot of great lessons from the ACD, and I think it should be adopted to support in all future campaigns. Thank you so much. So what we want to say is that, as initially I said, we have 4 sub-districts, but the program was implemented in just 3. We just want to propose that because of the effect, or because of what we have seen, because of the benefit, we will be happy if the project can be extended to the other sub-districts. Then we have done microplanning. Can we also look at doing digital microplanning, so that we can digitize all these processes, so that as we are all moving paperless, the microplanning process using the community members will also be digitized. So we will continue to ask for more support from BeSin and JSI, so that we can roll out more better interventions that will ensure higher coverage. Thank you.
Thank you so much. Next slide, please. Lisa, did you want to add anything before we go to the questions and answers?
No, I just to thank Emmanuel and Jones for excellent presentations. And there's been a lot of discussion in the chat, and I've been trying to answer some questions. I certainly have missed some. So yeah, looking forward to the Q&A.
Absolutely. No, thank you to all 3 of you. This has been a fantastic presentation, and really thrilled at the number and quality of questions that have come in. Just really interesting conversations happening in the chat. And also, before we get to the questions, just some comments from the participants about the importance of this work, I think is really important to highlight, about how learning about HCD and using it has really helped understand kind of why people are refusing vaccines, and how they can use this journey to health to shift that, and the importance of involving community members as a part of this process, rather than just at the implementation level. As Lisa said, there's been a number of questions that have been answered in chat, although certainly not all. And I'm going to raise up a few that have been just, I think people have echoed that they're very interested in getting responses to, but we will work with all presenters to get some of the responses to questions we don't have time for. So I want to start with one question that was asked by Khalid Abushaban, which was addressed in the chat, but I think there's been a lot of people responding to it. So I want to give a chance to address it live as well. And they asked, can I ask whether you use the classic HCD model of inspiration, ideation, prototyping, or a different set of steps? As well as, can you please explain the background for using HCD in microplanning and how this is different from using it in regular planning? I'll hand that over to you first, Lisa.
Sure. So we use the steps that were identified through the HCD tips process. And we didn't have time to do prototyping, but the process that we went through is effectively development of that collective action plans, resourcing of that action plans, and then the teams are implementing those action plans. But as Jones was commenting, there is opportunity to have iterative feedback from community members on how those processes are going. And we are also doing regular monitoring of the action plan. So Goss South, and Jones could speak to this too. He is specifically working with each of the health facilities. They're doing supportive supervision visits, talking and providing coaching around the action plans and the need to adapt as possible. And in terms of the decision to use human-centered design, so this really comes back to work that we JSI have done for the past decade in both Ethiopia and Uganda, where we've been using participatory approaches to strengthen microplanning. So a lot of our work really focused on how do we reach the hardest to reach populations. This was not focused on urban, but it certainly could be applied in urban context, which is what we're seeing here in Ghana. And that really we needed, in order to actually effectively reach these populations, we needed to have them engaged in the microplanning process and really understand what were the barriers that they were facing in getting vaccinated, and also what were some of those enablers that could help with that process. And as you have seen through this work, the community members were really critical in helping to promote vaccination, talk with their peers, design plans that would be more effective in reaching people with vaccination services. So that's why we decided to use human-centered design, really built on previous experience. And we wanted to, I think with this process, what I think is really important is this is a learning exercise that this data and evidence we are planning to, as a next step, use to talk with Ministry of Health on. These are the outcomes of integrating HCD into the microplanning process, both from community and health worker perspectives. It's been really positive. Is this something that we could think about trying to institutionalize and scale within Ghana? What would that look like? Would it necessarily be tied to microplanning, or would there be a broader effort to strengthen human-centered design capacity or capacity in behavioral science for health workers? And then just have it being reinforced through microplanning. I think these are a lot of conversations that we want to be having with Ministry of Health. I'll pause there and see if Jones or Emmanuel or anyone want to add anything.
I think I had some network challenge, so I missed the point you made. I'm not sure if it can be repeated. Sorry.
The original question was about what model of HCD did you use, and the background for using HCD in microplanning and its difference between using HCD for microplanning versus regular planning.
Oh, okay. All right. So if you compare the regular microplanning, health workers sit at the office and plan for the community. So we think that, okay, today we want to extend the services to this community. We don't consult them in any way. So when we brought in the HCD and microplanning, that is where community members were part in developing personas. So this one went through the normal HCD process with ideation, creating personas, using the journey to health. So they came out with the problem that confronts them at the community level. So now these are the barriers to vaccination, or these are the barriers to immunization. So how do we solve it? Then what do you think? I'm a member of the community. I'm a member of the sect. I reside in the community. We think that if you target this intervention at this time, it will work. We think that if you do this thing that you have kept on doing over the period and expecting different results, it won't work. So from the perspective of the community members, this is what we think. So they were part of the ideation process. They brought their issues to bear. Then the solutions were also brainstormed. So this is the difference between the traditional microplanning and the microplanning with the human-centered design in mind. So this one, you bring the person or the end users at the center of the intervention. And once you have the community members on board, the solutions that they will prefer will likely work because they are part of the decision-making process.
Thank you. I want to move to a question that Carolina Danovera asked about the outputs. They said, for further recommendations, we need to better understand the evidence. And this echoes a question they had asked earlier. What outputs were or can be used to evaluate the approach to routine practice? And they added in comparison groups as well.
So that's a great question, Carolina. You know, we didn't have the funding, unfortunately, to be able to do comparative analysis between health facilities that did, routine microplanning versus application of the human-centered design. We really did it based on just asking health workers about their previous experience with microplanning versus now having integrated HCD. What did that look like for them? In terms of outputs, again, the best that we could do were a couple of things. Get those qualitative insights from health workers and community members on the process itself, the microplanning workshop. And then what we have are action plans from each health facility, and we're able to, each of the action plans have very specific activities that have indicators that we're tracking. So at least we'll be able to look at specific health facility action plans to look at if and how those action plans are being implemented, what the outputs are from those specific activities, and with one of them being tracking coverage specifically for each health facility over the time period. It's 2 months. So we will have that data, but certainly it needs to be discussed of. So if the output is that every single health facility is doing an action plan, is that being tracked by each district? What does that look like? Can that be integrated into their routine practice? I think some of those certainly need to be talked through. And we would be welcome to, having expanded funding to look at this more specifically around looking specifically at microplanning versus HCD, also doing cost analysis, just to say.
Thank you, Lisa. And I think Emmanuel has his hand raised, so he may want to respond to that as well.
Please, go ahead.
Yeah, I just want to mention that one of the things that we are doing side by side the health directorate is to ensure that supportive supervision in the context of HCD in microplanning will be conducted. We've done one already. At the appropriate time, we'll be sharing the results once Lisa and the team put things together. But other ones are following. In 2 weeks' time, we would have. And just to mention that it's not the implementation that's just done, but we're also looking at using HCD to do other forms of measurement of strengths of each sub-district in terms of supportive supervision, jointly monitored by the community and the health workers. And so the regional health directorate is part of these, the district is part of it, the community members, key community opinion leaders will also be part of this. And so I just want to say that when applying HCD into microplanning, we still need supportive supervision as one of the things to do to ensure that we go in very well and we are sweeping off every other challenges that will be on the way, and make sure that monitoring and measuring progress together is key. Thank you.
Thank you so much. And we just have a minute left, but there's a lot of discussion in the chat right now just about the level of effort that's required to do this process, both time and cost, and whether or not this is feasible to do in an outbreak or epidemic, given that. And I just want to give each of you kind of a moment to respond to that and share any thoughts on that before we close out. So just very quickly. I don't know if anyone would like to take that for us. Lisa, go ahead.
Sure, I'll just say really quickly, this was not an emergency response situation. It was, we had the opportunity to work specifically with the districts to try to address stagnating coverage. And I'll also say that the reason why we chose microplanning is because it is a activity that is already done everywhere but all of the health facilities, and it was an opportunity to try to streamline and get community perspectives into a critical planning activity. And so that's why we really wanted to analyze and assess how to improve that planning process and if community engagement could help do that. So I'll pass to Jones.
Hello. Yeah. Thanks so much. So I was actually addressing a concern in the chat box. So I missed out. Sorry. Right. My final word. So my final words will be we will keep on waiting for the other parameters as raised by the other commenters or the other questionnaires to be measured, so that we can say that honestly this is the effect or this is what we have to show for the implementation of the HCD in microplanning. If you look at the nominal values, if you compare the performance of this campaign that we went full strength regarding the HCD approach, if you use the percentage or the coverage against the same targets for previous campaigns, then you see that we made significant improvements in this one. So on the face value, we can say that the approach is working, but then we should have a robust way of measuring it so that we can present it anyway. Thank you.
Thank you so much. Just on behalf of the Behavioral Science for Immunization Network, I want to say thank you to all the speakers today for sharing this fantastic work you've done and the results you've seen, as well as thank you to all of the participants. The chat has been just truly active and really exciting to read about how you are using these approaches and what you're seeing in your communities as well. So as we pull all of the information together from today's session, we will of course be sharing the recording and the slides with everyone today and resources as well. But we're also going to pull together some of the comments and thoughts that have been shared by everyone, because I think there's some really great insights there. So from your end, what we would hope to see is please do take our survey following today's session to share your feedback, both on today's session and what you'd like to see in future sessions that we host, and as well join the Behavioral Science for Immunization Network to keep this conversation going. There's a lot of great discussion here, and we'd love to continue this conversation, hear more from you, and answer some of the remaining questions as well. So please do join us online for that. Again, I'll just say thank you to everyone for joining today. Special thanks to the speakers, and we hope you all have a wonderful rest of your day. Bye-bye.
Thank you so much, everyone. Thank you.
Thank you,
Thank
team.
you.
Thank you.
Bye,
Thank you.
everyone. Thank you.
Thank you.
Thank you.
Bye, everyone.
Bye.
Thank you.
Thank you. Bye-bye. Nice presentation.
Bye, bye, bye.
Bye. Bye.
Bye bye.